For those of you who are repeat offenders, so glad to see you back with us here in Ottawa. Before I give you an overview of the day, I really wanted to start by reflecting on the importance of digital health in supporting and enabling and providing that really fabric for integration for system transformation. OntarioMD has gone beyond EMRs in terms of really what it takes to connect practices across the continuum. We've connected you to HRM and e-notifications, to OLIS and e-consult. For many of you, you've experienced our EMR quality dashboard. Lots of you are interested or on the journey to Connecting Ontario and OneID. It's a really important time for us as we leverage digital health to do more in integration and more in the patient's journey around ensuring information supports the continuum of care. We're soon going to be able to connect physicians to the digital health drug repository and the digital health immunization repository, again, providing access to really important sources of information for clinicians about the care they provide to their patients. All of these provincial tools designed to integrate with the EMRs because you've told us, clinicians have told us that's what works for them. We really need to be thoughtful about how we support our clinicians as they interact with the system so that they can worry about delivering the best care to their patients and not reflect on how hard it is to find sources of information. So that's what it's all about today, to provoke you and engage you, to expose you to really interesting things that are going on, to have opportunity to interact with the amazing vendors in our vendor space, and of course our amazing staff. We're hard to spot. We're here in purple shirts, so if you have any questions at all, please reach out. I'd like to sort of start off by making a special mention of HRM. And HRM in particular, for those of you that are connected, we're now about 180 hospital sites across the province, connected and directly integrated to about 10,000 physicians. And that's having a huge impact on the system. We've been acknowledged for this work, but really what it is an acknowledgement of the importance of the network effect. And so we're saving physicians, on average physician practices, about 30 minutes a day per physician. And we're adding value to the healthcare system in cost avoidance. So last year alone, we estimate that about $36 million in cost avoidance was accomplished because of this network effect, because of this amazing integration across the provinces of hospitals being connected. It's amazing. So now what do we have in store for you today? We've arranged two CME-accredited streams, and they both offer excellent learning opportunities. So there's something here for everyone today, no matter what your interest and experience level is. Most of our sessions are led by our peer leaders. You can find them in the green shirts, or our clinic managers, or other clinicians, and they focus on topics of interest that you want to hear about. So a really important part of our conference design is in fact reflecting what it is the attendees want to hear when they come here. So if you've chosen sessions and pre-registered, they're listed on the back of your this afternoon, they're vendors with by peer leaders experience in those specific products. Again, wearing green shirts, they're really easy to find. Clinician peer leadership is incredibly important for us. You'll find many peer leaders involved in the sessions. They're meeting with you individually. It's a great day to get connected and make those kind of resource connections to support you in the practice. I encourage you to visit the vendor showcase in the grand ballroom. Exhibitors have lots of great products bringing their innovation to you, and it's really important that vendors are here with us. They're such an important part of bringing our community together. Lots of refreshments. I invite you to join us at our new Quality Cafe in New Bridge 3, a new feature where you can kind of relax and check out some of our latest products, including privacy and security, our Insights for Care Quality dashboard, and meet with our staff. Please tweet while you're here. The hashtag is OMDESC19. If you haven't downloaded the conference app, that's where all of the navigation information is for the day, and it's available in the App Store under OntarioMD. Please give us our feedback using the app, because that's a really important way for us, as I said, to continue to make sure that the conference and content reflects the kind of learning and experience you want to have. So help us continue to improve. And so now the main event. It is my true pleasure and privilege to introduce Julie Drury. Julie is the chair of the Patient and Family Advisory Council for the Ministry of Health and Long-Term Care. She is passionate about the patient and family professional partnership and experience in delivering health. She facilitates and provides the patient and family perspective in healthcare policy and decision-making. As a mother of a child diagnosed with a rare mitochondrial disease, Julie has a particular experience in navigating the system in complexity, in care coordination, in palliative care, and patient safety. Her personal and professional experience are really now focused on advising government on key priorities and real impact in terms of improving the patient care experience. She has an incredibly important message. She has incredibly strong advocacy. And I have to say personally, I'm quite humbled by Julie, by her experiences, her honesty, her grace, her eloquence, and quite frankly, her challenge. What seems the most obvious and that for which we can and should change. There's no longer a rumble about patients having access to information about their care and their care journey. There is a demand, and it really is a conversation about how is it we enable patients in a completely different way to access information across their care experience. So please join me in welcoming Julie Drury to the stage, and then Julie will introduce our morning panel. Thank you.
I'm just going to do a quick test of the slides because I've been told we haven't tested yet this morning, so I want to make sure they will advance for us. No, they're not advancing. I can use the, why don't we do that? All right. Sarah, you forgot your coffee. Quick, run. All right, I'll use the clicker here on the computer. So thank you very much for welcoming me as one of your speakers this morning. When Sarah and Darren Larson first invited me to come back and speak at an OntarioMD conference, I thought, fantastic. I'm really passionate about the digital health space, about virtual care, about primary care. But I know other people who are just as equally as passionate. And rather than speaking at you, we wanted to create a dialogue with you. So we have an incredible panel for you this morning, and I'll introduce them in just a moment. One has become, they've all become very good friends. One I just actually met today, because we became friends on Twitter, on social media. And another is a member of the Minister's Patient and Family Advisory Council, and then another is a colleague who's working in this space of digital health and supporting clinicians like yourself and administrators to ramp up what they're doing around providing access to patients for their information. And so what I want to talk to you about this morning, just to kind of get us started off and get the juices flowing, is about the patient experience and the opportunities in digital health. You know, we talk a lot about patient-centered care right now in the healthcare space, and I have been running around looking for a definition of what that means. And I feel like when we talk about patient-centered, we've got the patient at the middle like a bullseye. And I would rather talk about patient partnership, because I think that's really the opportunity that we have here. Patients are becoming increasingly more sophisticated about understanding their health. We all know that they're researching online. We all know that they're connecting as peers and getting information from one another, either good or bad, and that they really do want to have access to their information so they can better understand what's going on with their health, but also so that they can better coordinate. And the reality is, in a complex healthcare system, such as the one we have in Ontario, patients truly do need to have the support to navigate the system. It has to be a partnership between themselves and their family physicians and their specialists, and they have to have equal information. Otherwise, they will continue to fall through the cracks of the system. There is really no way that we can have one holder of the information for patients and expect that one holder to be the person that makes sure that there are no cracks or gaps in care. And so that's really the foundation from which we want to start this conversation, that giving patients full access to their information, having a true partnership with patients is going to be foundational to not just a better patient experience, but better patient outcomes, patient safety, more seamless care, better care coordination. The patient experience is really about communication and information. In fact, the patient ombudsman in Ontario just released their most recent report. They had a 16% increase in patient concerns, and 90% of the complaints are around communication. So it's really about information sharing and transparency and openness and how we talk to one another. And I believe a foundation of that is how we share information. The reality is that, patients, they have a significant role in coordinating their care. They have a right to their information. In fact, we talk a lot about ownership, patient ownership of their information. Patients own the data, they own the information, but physicians and administrators in hospitals and in family practices are the custodians. And I'll tell you how challenging it can be. Patients are emailing, calling, leaving voicemails, they're even faxing. They spend hundreds of dollars sometimes to get access to their records, and they act as couriers. They run around with patient records or CDs. I still can't believe we're doing CD-ROMs for diagnostic imaging, but that is what we're doing still. And they courier that information back and forth between their family doctor and their specialist, between primary care and acute care, between whichever part of the healthcare system they're trying to navigate. And why are we still forcing them to do that? Why are we still living in that space? It does create problems with patient safety. It does create problems with communication. It does create problems with good care coordination. And quite frankly, I can't imagine for physicians that it's a comfortable space to be in. I know for our team, our healthcare team, for my daughter, were I not to be the courier of that information, they would lack the information that they needed to properly care for Kate. And so, and they were in an uncomfortable position. They were in a position where they didn't have all the information they needed to execute a proper care plan. And so I know as physicians that this is an uncomfortable space for you as well. The reality is digital health technology can contribute to better patient-centered care. If that's what we're talking about, Ontario, improved patient-centered care, this is one of the foundations. And I would propose that right now we're not doing it very well. We have tens of dozens of electronic medical records in the province. We have 87 patient portals that are not connected, where a patient would have to access the patient portal with their access code and an ID and a password, and they'd have to remember all that information, and they can't connect that information. We have electronic health records that are being deployed in hospitals that aren't communicating and talking to one another. In fact, here in Ottawa, we have two major hospitals that are deploying two different health records, Meditech and Epic, and the hospitals are 10 kilometers apart. And so I'm concerned about that as a medical mom and a family advisor in the system. I'm concerned about how we're accessing our information. And I'm also concerned for the clinicians that are supporting us in our care, because there you are, or those of you in the room who are clinicians, and they are trying to coordinate across multiple systems. And we're hearing a lot about physician burnout and the impact that that's having on physicians in the system. So we have a real opportunity here. I think we really do. We're going through a significant transformation agenda in Ontario right now. The foundation of that, I believe, is patient partnership and patient leadership. And then the right hand of that foundation is a really strong digital health strategy that is comprehensive, that serves physicians and serves patients first and foremost. And secondary, it serves the system and administrators. Patient portals, they allow patients access to their information. They allow us to coordinate our care. They support us in better communicating with our providers. I'm a huge proponent of the Open Notes movement. If you haven't checked it out, I would encourage you to do so. Open Notes is about patients being able to access their physician and clinician notes, and also being able to provide input, their own input into their notes, their own perspective about what's going on with their body, what's going on with their care. Patient portals help us to be better partners in our care as well. That information helps us to frame better questions, to better understand the care plans that are being outlined for us. Oftentimes when we're in clinic visits, We might hear 20, 25% of the information research is showing us. If we had access to our information post-visit and we were able to review that conversation, again, better engagement in our care plan, better understanding about what our physician would like to do with us in partnership, and we're better able to frame questions when we go back to that clinician for a follow-up visit. Open notes, again, it increases the transparency across the system, but we do have risks. We do have pockets in the province where we aren't really putting in the resources that are required. We have rural and remote areas of the province where access to digital information isn't as easy. We have friends, for example, in the Minister's Patient and Family Advisory Council that have a challenge with video conferencing because they simply don't have the bandwidth, the Wi-Fi to access that. And so we've got to think about that. What are some of the regional and remote disparities, and what does connected care look like for those communities? Comfort for technology is another. I think we're also obviously becoming a digitally connected society, but not everyone is digitally connected. So what does it look like for those patients in the system that aren't comfortable with connecting digitally, but still want access to their records and their information? Those are some of the risks. I think we can get into a broad conversation and have a full conference talking about data and use of data and how clinicians are accessing information related to their clinical information, but also how patients are able to control that information. In terms of opportunities, again, better information, we're better equipped to manage our care, better connected to our care team and to the healthcare system in its entirety, easier navigation and patient safety. And you're going to hear some of those themes from our panelists today. I want to leave us on a really positive note. I think that there's a lot of energy out there across the province. I had the pleasure of being at the National Healthcare Leadership Conference earlier this week, and there was a huge Ontario contingent there. And there's a lot of energy around this. There's a lot of hope for what a digital system looks like. We're not going to be able to back the bus up, right? Digital is here, but how can we frame it in a way that it's actually going to work for everyone? How are we going to frame it in a way that we're avoiding physician burnout? We're avoiding the 4,000 clicks a day. We're avoiding that interaction where the physician's looking at the screen and the patient's sitting here. How are we going to create a space where patients can partner with their information, where we can augment that interaction with our healthcare providers? So I think we're poised for opportunity. We're in a space right now of growing pains, and I think that's okay, right? Growing pains come with digital health, but I don't think we want to be complacent about it. I think everyone here in the room can be a leader in this space and push back about how we create continuity and how we create connection across the system. So without further ado, I want to introduce our incredible panel. And I mentioned how I know them. Our first panelist is Claire Dawn McCord, and I'll ask Claire to come up to the stage. Claire, I met Claire just close to 2 years ago. Claire is a member of the Minister's Patient and Family Advisory Council for Ontario. She's worked as a patient advisor for 6 years. And so she's been doing this work since she was about 12, 14 years old. She has been part of the CHEO Youth Forum, Children's Hospital of Eastern Ontario, the CHEO Research Institute as a patient advisor, the Ontario Structured Psychotherapy Program, and the Champlain Lynn Pediatric Planning Project. So she's been around as a patient partner. She's also been a guest lecturer about best practices for adolescent healthcare at the University of Ottawa. She's passionate about patient engagement, transitions in care, rare disease, and healthcare policy. When Claire was 9, she started experiencing what seemed like unrelated healthcare symptoms. And at 16, it came to a critical point when she was admitted to hospital with multi-organ failure of an unknown etiology. And during her many months of recovery, she was diagnosed with an extremely rare genetic disorder, neuromuscular disorder called Ehlers-Danlos syndrome. And Claire's experience with EDS has been exceptional in terms of how it is to navigate the system, both from moving from pediatrics to adult care, which is a big black hole in our system, but also moving between cities as a student and trying to access her healthcare information, healthcare. She brings a unique perspective to this world of patient advocacy. So thank you, Claire, for being with us. Dr. Danielle Pepe is my Twitter friend that I just met in person today. He's a family physician, member of the London Lambeth Family Medicine Clinic, and he's currently 1 year into clinical practice, which he shares with his wife. Daniel is involved in providing comprehensive family medicine to his patients, including surgical, assisting in orthopedics, inpatient, and palliative care. And his passions include patient education and, more recently, patient co-design. And Daniel, maybe you'll reflect on that a little bit when you come up here, because it was really an interesting co-design process that you embarked on. He's currently the editor of Teach and Learn Family Medicine, which is funded through a patient education grant provided by the College of Family Physicians of Canada. He's an adjunct research professor at the Department of Family Medicine and provides clinical teaching in both the undergraduate and postgraduate department at Western University. So Daniel, thank you for joining us today. And lastly, but not least at all, my friend Selena Brudnicki. Selena is the program lead of digital patient experience at the University Health Network. She's a recipient of numerous innovation, transformation, and leading practice awards. Her healthcare and digital innovation experience position her as one of Canada's leading authorities on patient real-time access to health information and data. And I'm emphasizing real-time because Selena knows how I feel about that. And also co-design and collaboration with patients around patient portals and access to information. She's committed to activating patients to take control of their own health, have safer outcomes, and be valued partners in their care. And she's been sharing her experience and expertise in local and national and international forums. Selena has also provided leadership to project teams to deliver initiatives that give healthcare providers from across the continuum of care more complete access to their patient health records, breaking down silos of information and delivering more coordinated care. Selena, thank you for joining us today. So we're going to take you through a bit of a conversation with the panel, and then we are going to bring you into the conversation. So take note of the questions you might have, or the comments you might have, or reflections as the panel is discussing this topic of digital health and the digital health space. And I'll be turning over to Sarah shortly to moderate a conversation with all of you. But first of all, to the panel. So first of all, thank you for all being here. And I want to start off with a question around your experience of why patients actually need access to their health information. It seems like a redundant question, but I think with the experiences of the panel, we'll get some additional insight. I mean, research and evidence has shown that patients are more engaged in their care and more activated to partner in their care when they have access to their information. So Claire, I'm going to start with you, put you on the spot. Beyond the research, Claire, in your experience, why do patients actually need access to their health information? What impact has it had for you as a patient to have access or to not have access?
I think one thing that we talk about a lot when you're talking about digital health and electronic health records is saving money and saving time for the physicians and coordinating care. But for me, I think the most important thing to remember is that having access to my records is the difference between life and death. It's not about saving time for me. I mean, it's great to have that ease of communication, to be able to log into my computer and have my results. But without that, you know, I could die. And I'll show her like a little story. So 2 weeks after my 18th birthday, I showed up to the adult hospital for the first time in my life. And I'd been in the pediatric hospital about 2 months prior with severe hyperkalemia as a result of my rare neuromuscular disorder. I showed up, I presented myself, I said, I think this is what's happening, it's only happened once before, it should be in my records. Because they had a file at CHIO that said, this is what she has, this is how she should be treated. I showed up with a potassium of 9.2 to all the healthcare providers out here, which is insanely high. Obviously not in my best self. Complaining like I had chest pains and irregular heartbeat, and they had nothing on me. So they pulled up my record, they had an x-ray from when I was 9 years old and I broke my pinky, and they had one set of CBC results from like 2011. And the physician looked at me and said, I have no idea what to do here because I've never heard of this condition, I'm gonna have to Google it. And I'm lucky that I had access to the CHIO version of my chart. I pulled up my results and I said, look, here, this is what they said. Without that, I could have waited another 3-4 hours in the emergency department and quite frankly died. And I know that makes it sound, you know, scary and egregious and all those things, but that's, I think for me, the most important thing. That's why I'm so driven to try and, I guess, shape the way that we move forward.
No,
Yeah, Claire, and it's such a dramatic story, and I've heard it before. And Daniel, can you reflect as a family physician, hearing Claire's story, how that impacts you as a family physician to have access or to not have access to a complete version of your patient record, and how you share that with your patients and the importance of that?
Yeah. So for me, when I hear your story, I'm kind of mortified because I think most new family doctors or residents get scared when the potassium's above, 5.1, 5.2. They start, and the physicians in the room know this, right? They start getting palpitations themselves. So to have somebody with a potassium of 9.2 who has to physically pull up their records and say, here, I think that's crazy. Like we talk about never events in healthcare. To me, that should be a never event. Like if you have that condition, you move through the pediatric system for 18 years, it should just be ported over, right? And to that, I think everything that happens in a hospital has to be copied to your family doctor, right? Now, I understand there's issues with access and people not having a family doctor, but I think a standard that we should expect is that every time something happens in a hospital, it gets copied to the family doctor, and then you should have access, right? I think when patients don't have access, it's a patient safety issue, and I think that's, interestingly enough, that's how the digital argument is being framed now. It's being framed as a patient safety issue, and I think when you frame it and you put that light and spotlight on it, it provides that sense of urgency that's not there if you just talk about it as, oh, this is a solution for booking, and oh, this is a solution for e-referral. When it's actually Claire's life on the line, I think it changes it, completely. So for me, I want all my patients to have access to their records. One of my patients got admitted last night to the University Hospital in London, and I know he has a long, complicated history, but I know the hospital has no idea what's happened in the last 3 weeks when he's been at home since his last discharge. So now I have to scramble to notify the team in the hospital, why is he there, what's he presenting with, what they need to do, because there's a whole backstory that they're missing. It's that piece of continuity that we need, right?
Yeah, absolutely. And Daniel, what does it look like in your office to provide access to your patients from your perspective as a physician to the health information that you have in your office? How do you do that? How is that structured?
So for me, we're trying to bridge the gap now, and I think that's where a bit of the co-design work that we came up with comes from, is it's me trying to give access to my patients. So right now, what can I do? I can print off a profile of what your history is, so medications, surgeries, allergies, all that stuff, but that requires me to kind of input it on an ongoing basis. If a pharmacy makes a medication change or dispenses a medication, I have no notification of that. I can download OLIS, the Ontario Lab Service, and pull down the labs myself and check each one off and then print them off to you, but that's not on your phone, it's not digital. If you're sick and you get rushed by ambulance, are you really saying, oh, and grab my binder as I go to emerge? I think that's crazy. And for me, the last thing that I've started doing the last couple of weeks is turning the screen. And I think for a lot of physicians, we're very scared of turning the screen and sharing the information with patients. So if there's one thing that I can tell the family physicians in the office, it's turn the screen. And show what you're typing to your patients and have them understand it. Because it's life-changing when they actually look and they go, no, my pain isn't intermittent, my pain is constant, right? They can correct your history, and then in that way you're kind of co-charting without even knowing that you're co-charting. So start doing it. I think everyone's always afraid they're gonna get a CPSO complaint if they share the information with the patient, but you're probably less likely to get a CPSO complaint if you just turn the screen. So for me, that's what it looks like in the office, but we have such a long way to go, like a really long way.
I love that. I love turn the screen. When I'm at my family doctor's office and she has the screen directed in a way that we both can see it, and we're both sitting looking at it together, and they're both able to look at each other. And so we're looking at the screen, we're looking at each other. There's this back and forth rather than her looking at the screen on her own and me wondering, what's on that screen? I really like that. Physicians are, this is a really interesting space and time because physicians are reporting increasing symptoms of burnout at an alarming rate. And I've been told, I've heard that this digital health demand that's on many of you is contributing to that. And Selena, you've got a lot of experience with working physicians, particularly in a university hospital setting. But I'm wondering if you can talk about what could be done to improve the physician experience with digital health. And if you could talk about some of the conversations and challenges and opportunities that you've had in working with physicians in this space.
Sure. I think it's probably common knowledge now that physicians are expressing burnout. And with that, I think part of the issue has been with, especially with EMRs, the focus on process and documentation and even billing rather than health, looking at the goals and outcomes. So I think part of that is the problem. And at the same time, with regard to patient access, historically, We see that it is the primary care physicians, the care providers, the health system leaders that are actually determining and controlling what patients are accessing. And I think part of that actually is not just about technology, but it's also cultural. And based on the experience at University Health Network, we have a lot of fear. It's a very different world when patients have access to their information. The conversations are very different. And I think that is part of the problem, that healthcare teams actually need some guidance on how do I interact with my patients differently and communicate with them.
Mm-hmm. Selena, can you talk a little bit about timing around access to information? I know that's been a challenge for you at UHN and something that you've worked through quite closely. Can you talk about that a little bit? And Daniel, you might want to weigh in on this as a physician and
sure.
when patients can access their information and who makes that decision?
So we actually debated, I think at UHN for about 6 months about the timing of release. Now I've actually implemented 3 patient portals since 2015. And just to give you some context, I think, Claire, you were probably 5 years old at that time. So that's how long the debate has taken. And really, initially, we actually separated our healthcare teams and our patients and care providers in the conversations. And we actually went deep into the real-time access. For our care teams, they were actually in the mindset that they should always be the ones to deliver bad news to the patient, if that's the case. And they always wanted to be prepared with all the care plans ahead of time to know the information before the patient walks through the door. But patients, on the other hand, said that they are actually anxious, waiting for the results. Sometimes it takes weeks to hear back. And in some cases, we've had rare cases where patients never heard back. So the debates happened, but what actually helped us was to bring our patients together with our care teams. And that's where the conversations really start. That's where the collaboration is. And I think it was amazing that we were actually able to resolve the issues in 2 hours. And everybody came to the table to come up with solutions to help with the fears, differences in communication and timing as well.
And if I recall, I think your patient surveys were that 96% wanted their information in real time.
Yeah, well, we surveyed patients 1 year after they had access to their information. So 94% of patients continue to want to have their information in real time. Yeah. And it's not just about communication. It's not just about being informed about their health, but it also is about patient safety.
Yeah, Claire, how do you feel about that? What does it mean to you to have access to your information in real time? And if you had to wait to get your results, what would that look like for you?
I've experienced both through different patient portals. The one that CHEO works on is if your results are abnormal, they wait 3 weeks before posting them, which is, in my opinion, the worst way you could possibly do it, because now you know something is wrong, and you're looking at it and no one's answering your phone calls because the receptionist only answers them between 20 minutes a day. And I've also experienced having real-time unfettered access to my lab results, and that has saved me a lot of anxiety. It's helped my physicians, and also it's saved money. I've been in the hospital before, and you're sitting there and you're waiting for your lab results to come back before they can discharge you. Maybe it takes 4 hours for those lab results to be posted. You get to see them. Your physician's not going to check them every minute. They have other things that are more important to do. Me as a patient, I can refresh that button every 5 seconds. I have nothing better to do. You're telling me that if I get these results and they're normal, I can go home? I'm all over that. And there's been times where I've been discharged, a day or 2 early from the hospital because I'm able to go in and get my blood work done, every 12 hours and see, are your electrolytes the right levels? And then I can go home. I live 2 blocks from a hospital. I don't need to be admitted for that. I don't need to take up a bed. I just need to have access to my own results. I know what the range should be, and if it's not right, having a physician go, okay, here's my number, call me if something is wrong, and I will come in and see you again. It's easy. It saves people, it saves time, it saves money. I don't know why it's not on a greater scale yet.
Thanks for that, Claire. And Daniel, from a physician perspective,
Yeah.
how are you feeling about this space of patient access to information and when they're actually offered access to their information? Who gets
Yeah.
to make that decision, and how do you feel about that from a physician perspective?
Yeah, maybe my perspective is a little different than some of the other family physicians, but I think we all make the decision, right? Selena designs the system, Claire says when she wants it, we say sure. I mean, it is the patient's data, right? If you made a request from hospital records and you said, hey, I want all my records from 1999 till now, they're yours. Like, you have that ability to do that. Are we quick at doing it? No. Are we efficient at doing it? No. Do patients get charged all the time for their records? Yeah. So, I mean, we could save the system a whole bunch of time, money, and effort just by giving patients access. And I think for family physicians, it's actually an opportunity to get better, because then you have to be accountable to patients. If they send you a message and they say, hey, can you explain this to me? You have to know how to explain what a normal potassium is versus an abnormal potassium. So I think it's kind of a rising tide that lifts all ships. So I'm not necessarily afraid of it. Maybe I'm naive, maybe I'm stupid, maybe I haven't, been around long enough to actually know any different, but I think we have to do something different, because right now, so my wife and I in our office send a message to everyone for normal results. So normal potassium, A1C for diabetes, cholesterol, and we send it to everybody, and the other docs in the office go, why do you do that? And I said, well, so they know, so they're not worried about it, because I don't have another way right now to inform them of their results. And it takes up probably an hour and a half of my secretary's time a day. Right? So I think if patients had real-time access, that's an hour and a half where she could spend dedicated on the phones, right? And if we didn't have a fax machine that they had to receive results, download them, upload them, file them, label them, send them to a message, if all that collapsed down into, okay, everything automatically downloads into your chart, then we're sitting pretty. I think docs in the room are probably dying of death by 1,000 digital cuts. It's a login and a password and a click and a click and a login and a password. It's nauseating by the end of the day. The medicine's the easy part, right? So we've started to implement tablets that actually take a history, so I can give it to Claire if she's coming in for her blood pressure and say, hey, Claire, can you answer these 5 questions about your blood pressure? Downloads into the chart, my subjective notes are done, my nurse does the vital signs, and then we can actually have a conversation for 10 minutes instead of me sitting there doing this. Like, I'm a really expensive typist in the healthcare system. I don't think you want your taxes going to me just typing notes. It's crazy.
I think that really resonated. You had a little laugh on that one. I'm taking a little bit of a departure from the third question that we had planned, because I want to ask you all, who should be paying for this electronic medical record space? I'm hearing a lot of the cost is being downloaded to physicians. I'm hearing that physicians say, look, I'm all about virtual care and emailing or texting or phone calling with my patients, but there's no what's the word, billing code or whatever it's called for that. Who should be paying for that? What should that look like? Do we need to evolve that space? And I don't want to get into sort of a negotiation of billing codes. That's not the point here. But how are we going to make sure that physicians can do this in their daily practice? To your point, Dan, you're spending an hour and a half a day doing it, which I'm sure is not paid time. So how do we work that out? What does that look like?
It's interesting. I think we are at a tipping point in Ontario where patients, families, caregivers, administrators are all saying kind of enough is enough. And I think we have to stand up and say, okay, we have to do something different. We can't sit and do it in the old ways. I mean, in the hotel room this morning, I spent 40 minutes sending fax requests back for scripts. Like, it's crazy. I think we all have to maybe pay a little more, maybe invest a little more. And I think we have to look at all the structures in Ontario and say, what are we getting value for? What are we not getting value for? What's good for patients? What's not good for patients? And how do we change and shift the money? And they're difficult conversations to have, because it means certain organizations are going to have to collapse. Certain things and old ways that we've done it are going to have to change. But I think in the end, what's going to happen is the experience will get better for physicians. The experience will definitely get better for patients, and will improve safety. And I think safety has to be that aim that we have to go for. We have to have seamless data from one end to another, from the time Claire's born until she's 89 years old, or however long you live, right? We need that data available at the tip of our fingers so that you can make those timely decisions. Because I think every physician would tell a story of when they didn't have access to information and when there was a near miss or there was an error, right? And those have to be never events. So for me, I think I'm willing to pay a little bit more for it, but I think we have to pay collectively as a system and decide.
Thanks for that.
Yeah.
You know, part of the reason I'm here is that OntarioMD, Darren and Sarah and their team really value patient partnership, and that's been pretty clear from since I first got to know this organization, and from the fact that we've got a patient partner on the stage. And Selena, you've had a lot of experience with collaborating with patient partners and co-design. I wonder if you can offer some insight as to what that should look like in this digital space. how should patients be included in helping to inform how EMRs are structured or EHRs are structured, or how we're talking about this virtual care and digital health space?
I think the answer, or the key answer to that, is collaboration, and having the leadership champions at the table that have a wide representation of roles. I always hear from time to time it should be health system leaders, it should be administrators, it should be physicians, et cetera. But I think you don't get the perspectives of all of these people unless you have everybody at the table at the same time. And with the patients, I think that patients need to be at that table from the very beginning as part of planning. You can't just decide things ahead of time and then bring patients in later. You don't get that huge perspective without that collaboration.
Claire, we need to hear from you on this. How are you feeling about patient partnership, and what is the role of patients in this space?
I think patients should always be in the center of their care, and I think you should have access to everything that you need, be that a specialist to talk to, your doctor's phone number, where you can actually be able to speak with them, and patients should be involved in collaboration from day one. And I actually wanted to comment on the question you asked Daniel. I might be naive in the sense because I'm not an administrator. I don't have to handle electronic health records ever. But for me, moving from Ottawa to Hamilton meant moving a box this big, which doesn't even contain all of my medical records, just to give you an idea of how many I have, with me to Hamilton to store under my bed in case I ever needed anything. That access that we have has to be, spread across the province, spread across the country. Everything has to be interoperable, and it is about patient safety, and it's about, even if you want to think of it from a physician's point of view, if you don't care about patient safety, it saves your reputation. If your patient goes, hey, you missed this, at least they're telling you now, and they're not showing up to the hospital, and some ER doc is going, who missed this? It's a pretty, it's a pretty big deal.
No, you're totally
It's a treatable
right.
moment, right? Having to move a box like this of your health information as a student from Ottawa to Hamilton because we don't have any interoperability of our health information. It's pretty profound.
Took up precious space in my car.
I used to say that I was
very full.
It was very full. Yeah, in amongst all the other things you need for university, and I used to say I was the queen of the binders. I think Kate's got about 5 different binders that we use to be able to communicate her information. Daniel, a last comment to you, because we met on social media through Twitter, and we met because Daniel started a crowdsourcing patient engagement co-design process on social media for his office. And I would love for you just to kind of describe that a little bit for us, what you did and the impact that it had for you.
Yeah, it was kind of an interesting thing, because I was talking to patients about, how can we make the office better and what can we do differently, because we're new practice, and so we're always trying to improve, right? And so my wife and I were at the cottage, and I had kind of hotspot Wi-Fi on my phone, and I went on Twitter and I said, okay, patients, let's come up with a way that we can actually help you organize your doctor's visit. Because I don't want to tell patients, okay, one visit or one problem per visit. I don't think that's fair to patients. I think sometimes you miss a bigger diagnosis, maybe like in your case, Claire, where there were a couple different symptoms that were kind of unrelated, but were actually related to an underlying condition. And so we just started crowdsourcing. I think I tagged you, I tagged Maggie, I tagged a couple other people. It started getting retweets, and the comments coming in were amazing. And I think what patients couldn't believe is that a physician, whoever I am, was actually listening to them, and we were just coming up and editing this document. And so we had 5 versions over the course of 2 weekends. Then I think Cognizant came in and said, okay, we'd like to make it a custom form, and so now it's a custom form on Cognizant. Then we've made my care plan for docs, so if you want to download it, it's a custom form on our website, and you can actually use it to co-design a care plan with patients. And it works great, because how many times have you talked to a patient about 7 different things, but then you forget 4 through 7, because, you're talking, you're charting, you're trying to keep track of the plan. It was a great experience. I think we had almost 250,000 engagements on it, and so it's one of those things that there's obviously an appetite for, and I think what doctors don't realize is that if you work with patients, your life will actually get easier. There's this fear or myth that we have to bust that when you work with patients, your life is going to get harder, because now I have to chart and I have to explain and everything else. I think that's wrong. I think all we need is for the tech, so if there's vendors in the room, we need the tech to catch up so that when we take a history or take some notes, it actually gets funneled into the chart and the patients get a copy of it. Like, it's not rocket science. You look at what Apple and everybody else can do. The tech is there. We just need the will, and I think that's you guys in the room and whoever else is listening on live stream, right, to really push it. So.
I love that, and I'm leaving that as a closing thought for this part of our panel. I want to invite Sarah up, because Sarah's going to take us through a conversation with all of you. So we've got roving microphones. We welcome any questions or comments or reflections that you have. I'm going to join these guys.
So you're provoked. I know it. I can feel it. I was provoked. And my first provocation certainly came from Claire, and even how we talk about the impact of our work. And it really is about patients. It's not about saving time and efficiency and effectiveness. It really is about care to patients. So thank you, Claire. That kind of was like, oh, I think I need a different frame for that conversation. But it's really the opportunity. They're an amazing panel. They've got great experience to ask your questions of the panel, and there are microphones, and so if you just put your hand up, please take this opportunity if there's a question you'd like to provoke of one of our 4 amazing panelists. In front.
We're waiting for 1 second. Well, apart from maybe Daniel, could you please be the next OMA president for us? That might help matters. I'd like to see some of those things that you've advocated for in the negotiations. Some of the new doctors, when they join, have new perspective on work. I'm not sure I'm seeing exactly the same spirit all the time in the new doctors that are joining that you're expressing. Can you tell me a bit more about what efforts through organizations, College of Family Physicians, for example, the universities, what are they doing, and through the mentorship programs when they come out, to actually emboss people with the kind of discussion comments that you've had? My own family doctor is a wonderful person, new graduate from McMaster. I often ask him at the end of my session, what's my homework? He looks at me with a quizzical eye. What are you asking, what's my homework for? Yeah. And I say, because I'm part of the team. Yet, why hasn't he got that in his quiver? What are the colleges perhaps doing or not doing that you could point to, and maybe what leadership is required to make sure that the kind of attitudes you're expressing today are more evident across the board?
Thanks for the question. It's an interesting challenge because I don't want to necessarily say that certain colleges are doing things and other colleges aren't doing things. I think if we want to reinvigorate the colleges, which I think is what needs to happen, we as a collective have to look back to the colleges and say, these are the skills we actually need today. And I mean, I'm talking to the guys at Western saying, we need a day on digital health. We need to explain to them how they can use an EMR, how they can optimize their searches, how they can optimize patient messaging. Because if it wasn't for the people in my office who are OntarioMD peer leaders, I would have no idea coming out of residency. And so I think we actually have to look at our medical education piece and kind of say, how can we do that better? And then we also need these grassroots networks, because I think, maybe this is my own personal bias, but with certain legacy brands, CFPC, OMA, OFCP, or OCFP, there's all these different organizations that we have, but I don't have a clear view as to what each one does. And I think they need to do a little bit more reaching out, but then they also need to do a little bit more listening. Just like family docs need to listen more to patients, because if we listen from the bottom up to patients and caregivers and medical moms, then I think that's how we actually get better. And I 1000% agree with your thing about the homework. I give everybody homework. I think my patients are kind of annoyed, but when they come in with a vague symptom, I'm like, give me a diary, do an Excel spreadsheet, email it to me, send it through the portal, I'll download it, I'll review it, because that's how we get better, right? It is a team effort. And I think we have to get away from the traditional definition of, I'm the doctor, you're the patient, you're gonna listen to what I say, and I'm gonna let you talk for 16 seconds before I interrupt you. I think it's totally backwards. I think we have to optimize technology so we can pull all the data in front of us and then make a really smart decision about what we have to do in terms of next steps. So, does that answer your question? Maybe, sort of? Okay.
I'm going to add to it just really briefly. Wait for my mic to get turned on. I'm the red one. Thanks. So one thing I just want to make mention of is that there is this space in the medical schools, I think, for adding in a component around patient partnership. So at the University of Montreal, for example, in Quebec, the Centre for Excellence on Patient and Public Partnership is embedded in the School of Medicine. It's a patient-led and delivered program with 2 co-directors, a patient partner, Vincent Dumez, who you might know from the National Pharmacare table with Dr. Hoskins just recently, and his physician partner, that they co-lead this directorate. And this directorate is responsible for ensuring medical school education for trainees from first year all the way through residency around patient communication, patient partnership, co-design, everything that would help to facilitate improved patient partnership between clinicians and patient. And I think that's something that is an opportunity here in Ontario. We've got 6 schools of medicine, I believe, that we could probably look at some kind of framing around an educational model that starts to talk to our clinicians that are growing out of these schools about what actual patient partnership looks like and what that relationship looks like, the homework relationship, as you said.
Any other questions?
Yeah, hi, Lee Donahue. I get to wear a green shirt today. The color choices are determined by OMD, but the green shirts are here to help you. I'm also involved at the OMA and have been for a lot of years, and I currently serve as the board director for many of the physicians that are here. So applications for board directors and presidents are happy to take, and if you get enough people to sign him up, we'll get him elected and then move from there.
There you go.
You do have to come to council, though, so that's the pitch from an electoral perspective. But I do think there is a change that's happened, and a lot of the change that's happened is from what you guys are talking about in terms of technologies and what do technologies do differently, right? And so I, on the one hand, think in some ways you having a set of paper charts is, for many of us, a day of bliss that we're not dealing with an EMR that's not working. So there are times in which the system is down and clinicians are like, oh, we can go back to a different way to be. And one of those different ways to be when the system is down is to actually look at patients and to interact that way. And so from a patient perspective, I'd like to hear reflections. And from a parent of a patient perspective, I'd like to hear those reflections as to how do you find the technology in the way at the time of your clinical visit? Do you want to start with that one, Danielle?
You go ahead, Claire.
At the time of visit, I mean, for me, like I've had paper records have been very convenient for me, and sometimes I have a little red binder that's like the summary. It goes in my bag. I have a go bag to go to the hospital. Everything's in there: toothbrush, charger, and those records are fantastic. And I am not opposed to carrying a small, 10-page report. Yeah. In my perfect world, when I swipe my health card, that 10-page report would pop up, no matter where I am in the country. But I understand that that's not, something that can be done realistically. Pardon?
Maybe.
If there were an HRM report that comes from patients,
Right, Lee.
Sarah, get on it.
Yeah.
Come on.
Yeah, let's make it happen.
So similarly to Claire, we had a go bag. Same things in the bag: toothbrush, change of underwear, whatever else that you needed, and a document called a SPOC, a single point of care document, which in Kate's case was 5 pages. I also was at her binder with me that had more detailed information, all the most recent lab results, all the most recent diagnostic imaging, clinic visits. But the SPOC was the document that offered a fast look for the clinicians that were going to be engaged in her care in the emergency department. And I would make sure that I had multiple copies, because I learned very quickly that the junior resident, the senior resident, the attending, the nurse, the multiple people that saw Kate all wanted a copy. So like, can I get a copy of that? Because it was very quick and easy for them to access and to look at. They wanted the paper-based copy because whatever was happening electronically wasn't efficient for them. And I think that speaks volumes. And it was also the document that we used to be able to navigate between different healthcare settings, because we weren't always at the Children's Hospital in our city. We were moving between different cities, actually interprovincially as well. And had we not had that in many specific situations, the physician would have had to rely on me as a storyteller. And I think there was a reliance there, but there was also a bit of, not skepticism, but also some, the clinical lens that was missing for them. But that document which was written by her clinical team, was gold to them. Why can't we have that electronically, I guess? Why can't I swipe Kate's health card and have that pop up, similar to Claire?
So I'm going to take there's a question in the front. Darn, I was taking that prerogative of the question. Go.
Sorry, I'm Michelle Anawati. I'm a family physician in Orleans, and I have a primarily Francophone population. And I'm also an academic physician. I'm clerkship director at the University of Ottawa. So I just want to know, like, I'm all for real-time access, but how do we address language barriers? So most of our documents from the hospitals are in English. There's a huge difficulty for our population to understand the medical jargon and language, and it's not translated or accessible for them, even if they have physical access to that. So what would be a solution to that? How are we going to address that translation issue? Because it's absolutely a necessity for a lot of our populations.
Maybe if I can, I'll start answering that one. For us with patients, naturally for the very first time when they're seeing their medical record, it is very confusing. So what we have done within our portal is actually to provide links to education. So starting with test results, we are linking to information about why you're even going in for this test and what it might mean. So starting with some basic information there. I actually had a patient on Monday who told me the very first time he saw his clinic notes, and especially the doctor's notes, he didn't have a clue of what it meant. And over time, there's an actual education that happens, and a lot of times it's the patient educating themselves. So again, it's linking to that terminology. He said, today, I actually can read it and I understand what's going on. And it's being able to focus on the important conversations as part of that visit, rather than spending time to just get results and you have to come back to understand more.
Can I jump in on that
Sure.
for a second?
Yeah.
So two quick stories. So first quick story is I saw a guy last Tuesday in after hours clinic, and he was from Kenya or Mozambique, and anyways, he came in and he didn't speak English, he spoke French. I don't speak a ton of French. It's like, je suis tu es, il est. That's as far as I go. And so he brought his 7-year-old daughter in to translate, and she knew some words, but she didn't know some of the medical jargon. So I pulled up Google Translate, which I don't know if you use in clinic, but it's like my favorite thing ever. So I go English to French, and I just do conversational back and forth, and that's how we did the visit. So that's my digital workaround, I guess, for that. And then the second story is we had a patient who came from Israel who had some really complex abdominal surgery, and I had no idea what they were describing. And I mean, I had done a 1.5 years of gen surg before family medicine, so I thought, oh, maybe I'll look at the scars and understand it. I was totally confused. So again, I opened up Google, and they've got a functionality where you can actually do English to Hebrew or Hebrew to English and scan over the image, and then it translates the words. And so that was another workaround. But I mean, why can't these technologies be embedded in our day-to-day life? Canada is a very multicultural place. I think they should be, right? Because then you talk about the vulnerable populations who aren't necessarily incorporated on a digital standpoint. What about all the newcomers? Why can't we have some workarounds so that they can be embedded into all of our family practices and not just 1 or 2, specialty clinics?
I think Google Translate is an option when you're having a conversation, but if we're talking about real-time access, that patient wants to know what that
Yeah.
is. I think that's a little,
It's different.
not enough.
Yeah.
They have a right to have it in French.
Yeah.
I think
That's
sort
a
of
great question and a great call to action, for sure.
sort of building off what Selena was saying about having an educational standpoint with links embedded, I think those links should be a provincially created standpoint that is offered in English and French and other major languages in this country, because people don't necessarily know. If you're looking at this, like, a lot of kids don't know what potassium is. Like, they're like, oh yeah, I learned about that on the periodic table. To be able to click on that, see what it is in other languages, see what the levels mean, what does a high level mean, what does a low level mean, what kind of symptoms are associated with it. I think that's something that should be easily, you can just like click
Yeah.
it and understand.
Can I play devil's advocate
So
with that?
Yeah.
I know we're getting really close to the end, so I
Oh,
want to
yeah.
give the panel the opportunity to give us homework on the theme of what is one thing that you'd like to tell this room that you would like to give us as homework based on the conversation this morning. So I'm going to start with Selena at the end. What's our homework?
Well, I'm going to challenge everybody in this room to think about how you start collaborating, not only with your colleagues, but also your patients. And to make sure that you get the perspectives, from your patients, their family members, caregivers, because I think that's where the true collaboration comes, that's where the true solutions will come as well.
Claire.
Sort of building off of Selena again, I think just simply asking your patients or whoever you're working with, in your perfect world, what do you see happening, and see if you can make it happen.
Daniel.
So for me, it'll be two things. One is turn the screen. That's, I think, simple, easy change management that everyone can do today or tomorrow. The second piece is really advocate for HRM, because I think HRM is low-hanging fruit and low-hanging technology that can actually allow us to push and pull records. It can give us Claire's desired solution of swiping and getting records, and I think if all physicians ask for it and if all caregivers and patients ask for it, we can get it. We just need to be really loud and persistent.
So I'm going to build on the theme of health literacy. I think the one thing I would leave the audience with is what information can you share today, tomorrow, going forward with your patients that will help them better understand their care and the plan that you're outlining for them. So is that giving them particular access to their information? Is that offering them a link to learn about different blood levels or diagnostic imaging, whatever it is? But what's the one piece of information that you can share with your patients to help augment their understanding of their care and their disease and their condition?
Please join me in thanking the panel for really an extraordinary start to our conference.
Good job, you guys.